Good morning all. Respected Vijayakumar sir, thanks for giving us another opportunity to take over the first session. Like the kids whom you see over here, this is not a questionnaire session, this is not a panel session, neither we are not going to moderate. We are just going to project 3 cases. It has been very nicely put up by our teachers. So we will just go through this session, the patients with limited details. How we are going to approach these patients. That is what we are going to do in the next 1 hour or so. So we will be like every one of us, like the kids over here, we will be taking the mistakes or the correctness or the clarity that we want to manage these patients from our teachers. So that is the idea. Now we will go on to the first case. Dr. Rajesh.
Yes, thank you, Dr. Gauri. So, good morning to all. And so let me start with So, what are we going to do in this 1 hour is that we are going to discuss about diabetes in the young. And for this, see, the reason behind is that most often we see young individuals presenting to us with hyperglycemia. And what happens is that when you want to classify the type of diabetes in these people, it is most often not straightforward. They don't neatly fit into some of the criteria that is given in the textbook. So what we have done is that we have taken 3 cases, 3 very short cases, and just wanted to express and highlight how diabetes in the young is it's like a spectrum. So let's move on to the first case here. Here you can see a 19-year-old male. All our patients are 19 years here. So here it is a 19-year-old male, and he's studying in a private engineering college. Look into the BMI. BMI is 17.2, and does not have any obvious symptoms except for some mild symptoms of fatigue and tiredness, something like that. And you can see there is no features of insulin resistance, no abdominal adiposity, and you can see no other acanthosis. So no features of insulin resistance is here in this particular patient. And otherwise absolutely asymptomatic, no abdominal pain, no comorbid conditions. Look into the family history. Father has diabetes, and diabetes was there from the age of 42 years. And father, by profession, if you look into it, he's a bank manager by profession. And his diabetes is well under control with oral drugs alone. So that's the family history. Otherwise, there is no issue of any autoimmune disease in the family. Vitals are stable. We're not going to look into the other labs. Take it for granted that all these parameters are going to be normal in this particular patient, because our focus is just going to be the classification of diabetes in this group. So, if you look into the parameters, blood sugar parameters, you can see the fasting blood sugar is 176 milligrams per deciliter. Postprandial is 224 milligrams per deciliter. HbA1c is 8.3. He is adequately hydrated. There is no obvious signs of dehydration in this patient. And urine ketones are negative for this particular patient. So now there is a confusion. So here there is a patient who is 19-year-old with a low BMI. BMI is only 17.2. So obviously what we think is that we wanted to rule out whether this patient is having any type 1 diabetes or not. So what GAD65 was done for this particular patient. GAD65 was negative here. And again, we wanted to look into the beta cell reserve of this patient. So what happened? A C-peptide was done, and you can see the C-peptide is 1.8. So this is the case scenario. So with this, let us learn from our experts here. Let us ask from Professor Venkatraman sir here. Sir, you have a 19-year-old patient, an young individual, and the BMI is 17.2. Usually what comes to our mind is that when they present, when in this age group at this BMI, when somebody presents to us with hyperglycemia, we always tend to diagnose type 1 diabetes in this group of patients. But here, looking into the GAD65 negative, probably you can say that there is no autoimmunity here in this particular patient. I think, sir, you are not comfortable. We'll remove this chair, sir. Yes. So probably, it doesn't fit into a type 1 straight away. And moreover, we can see that the C-peptide is 1.8, which clearly tells you that there is a beta cell reserve in this particular patient. So probably what we can take it is that we are not dealing with a type 1 diabetes at this particular point of time. So what else could it be, sir? Can it be a type 2 diabetes in this particular age group? Usually, it is not unlikely to see type 2 diabetes at this age group, but usually they will be obese. But here with a BMI of 17.2, not a type 1 diabetes, what else could be there and what could be the pathophysiology in this particular patient which is causing diabetes in this particular age group and BMI?
Thank you, Rajesh. Very interesting case. I wish we had done the rehearsal as we used to do earlier. I think today we have not done it. Anyway, that was in a lighter vein. What I thought was, when it comes to diabetes, quite often, in clinical medicine there are two things. Challenges in diagnosis, challenges in management. In diabetes, I believe, it's always a challenge in the management. Quite often the diagnosis is straightforward because we are dealing with the bulk of type 2 diabetic subjects, but not in a case like this. So a young individual with hyperglycemia have been exhibited some OHAs. The control is not good. HbA1c is 8.3. So what I thought was, in such cases, how I proceed is, when this patient gets admitted, or in the outpatient you treat him, you just have a working diagnosis. Okay, because at that point of time only few parameters are available. I would say working diagnosis in this patient, maybe let's assume the fasting is 220 and postprandial is 380, he has had some polys, he has had some weight loss, lean, no features of insulin resistance. Working diagnosis will be, in my opinion, I'm sure Professor Madhavan and Professor Anand will share their inputs, query type 1 diabetes. So that will be the working diagnosis. Then you have these investigations, then you have the opportunity to give a functional diagnosis. Lean, young, diabetic with low normal C-peptide response or good C-peptide response with autoantibody negative. This will be the functional diagnosis. Third thing, if you are confident enough, if the investigations and then the pattern of behavior of this patient helps you, you can have an etiological diagnosis. So first, functional diagnosis, query type 1 diabetes, initial diagnosis, that is for you to start on. So this patient, certainly I will start on insulin because of his age. Subsequently, with these things available, you have a functional diagnosis, a lean, young, diabetic, let's not commit on type 1, type 2, etc., with good C-peptide reserve or low normal C-peptide reserve with antibody negative. And subsequently down the line, you can harp on. What I'm trying to say is, let's not probably focus too much on the etiological diagnosis, rather the intricacies of the disease can be captured in the diagnosis, because that's what we can do at this particular point of time.
Sir,
Yes, sir, please.
So you want to add, sir?
Yeah. Please, sir, please add up, sir.
I totally agree with Dr. Venkatraman. The age of onset, whenever we talk about classification, we take into consideration some certain very important parameters. One, the age of onset, the way of onset, whether it is insidious or it is explosive onset. If it is an explosive onset, I will straight away say, even if the urine acetones are negative, I just say that, like Dr. Vijayakumar pointed out, still can be a type 1 diabetes. And there is always an entity called slow onset type 1 diabetes. That is very common in the Indian phenotype. We have already established some 40 years back that the Indian phenotype of type 1 diabetes do not have the explosive onset like the Caucasian type 1. So sometimes it can be a slow decline in the C-peptide. Ultimately, this patient may become insulin dependent. But of course, on the other hand, young onset type 2 diabetes is not uncommon. And it can happen, again in Indian, we know that so many youngsters are becoming type 1 diabetes, type 2 diabetes. So young onset type 2 also can be a possibility. And as Dr. Venkatraman correctly pointed out, I think initially I may not expose him to oral hypoglycemic agents.
Is there anything against Modi in this patient? You haven't taken a full
family history, only one generation, sir.
You have not taken a full family
Only father is diabetic.
Suppose the grandfather is also
Grandfather is not diabetic, sir.
Suppose he is a diabetic.
Okay,
Will you
sir.
think of a Modi in this case? Will you do some genetic studies?
See, obviously, the absence of family history cannot rule out a MODY. We all know that because diabetes is very, very subtle, and most of the cases, the elderly people, grandfather, wouldn't have diagnosed to have a diabetes. So that's a good suspicion, we can have it. But that could be a good suspicion. But my question is, suppose if here only GAD65 is actually done. Suppose imagine IA2 is done, zinc transporter antibody is done for this particular patient, and we have completely ruled out autoimmunity at that point of time. Is there a scope that this patient could be a type 2 diabetic? In case at this BMI, what could be the pathophysiology which can lead to hyperglycemia in this particular patient?
Sir, are we, to put it more specific, like is that one antibody sufficient enough, GAD65,
Correct.
or do we need to add 2 antibodies, sir?
2 antibodies to confirm a type 1
Yes, yes.
diabetes. Any ultrasound done?
Ultrasound is normal, sir. He doesn't have any abdominal pain. There is no history of pain abdomen, sir. Yes, sir. So in case if both these antibodies are negative, so we do ICA, IAA, GAD65, zinc transporter, all antibodies are negative. Let us presume like this patient comes with all antibodies negative. Now, where do we stand in our diagnosis, sir?
Because we know that
Sir, mics.
the antibodies can still be negative.
Sir.
So when do you follow up this patient for autoantibody again, sir? Do you repeat?
Rajesh and Gauri. Number one, I think we did have an international consensus on approach of diabetes with young onset diabetes. Now, if the autoantibodies are negative or even positive, if the endogenous insulin reserve is reassuring, then the clinician is probably justified in treating them with OHA, wherein the discretion becomes much more important. For example, if this particular patient, let us not bother about the label. If he is going to lose weight, if he is cachectic, I think irrespective of the label, he has to be on insulin. That's number one. I think we did have yet another type of diabetes, if you remember, right, which we discussed in our forum, type 5 diabetes.
So that we will come in a minute's time, sir.
Oh, you got that agenda in the down the, okay. So it's probably, so at this point of time, as I keep on repeating, without expecting a label in this particular individual, I'm sure you will agree, let's have a functional diagnosis. Young diabetic with autoimmunity negative and low normal C-peptide or preserved C-peptide. So that tells you, if somebody is going to start this patient on OHA, he's not wrong. He has got some consensus support to do that. The C-peptide is there. How long? We do not know. On the other hand, if you feel he is losing weight, I want to reach the ideal body weight for obvious reasons, then he has to be on insulin, it's not wrong. In other words, a functional diagnosis will be much more appropriate. I think over the sequence of time, or a temporal relationship, maybe retrospectively you can make a diagnosis, which I feel is fairly acceptable in clinical parlance.
Serial C-peptide estimations.
Sir, so the patient sits in front of you today, sir, in the OP. So how are we going to manage, sir? With these data, right now he is there, sir.
I will manage with insulin.
And how long you are going to give insulin for this particular patient, sir?
Yeah.
Now, because we have
two things. No, please, I think anybody has got other options. Because with a BMI of 17, even though...
Why not oral antidiabetic pills?
Why?
Because we have good C-peptide reserve
So we have
also.
a good
I always believe that just like in the obese individual, your endeavor should be to reduce the weight. In the case of lean and cachectic individuals, your endeavor should be to increase the weight towards the ideal body weight, because that is associated with a lot of protection from other ailments as well, which is exposed in the community. So I personally feel that there should be some amount of balance between the two, not go by the rigid guidelines of, as I told you, the C-peptide is good enough, but it is probably 1.8, maybe towards the lower limit of normal, it is just exceeding. It's a question of time, as Professor Madhavan pointed out. Maybe down the line, when there is a decline in the C-peptide, then you know probably you are dealing with a beta cell which is gradually losing its function. So that's from the point of view of observation and then further follow-up of the patient. I would certainly start this patient on insulin, number one. Down the line, if the insulin requirement is very less and the control is very good, and certainly there's going to be some sort of a pressure, then maybe you are justified in withdrawing the insulin and then introducing the OHA. That will be my approach in this particular case.
In that case, what OHA will be introduced, sir?
Yeah. So taking his BMI into consideration, probably this will be a case where I would like to start this patient on an SU and certainly metformin as well. Now, when I say metformin, I am aware of the fact that this is a lean individual, because now I think, see, metformin has been there in our practice for a long time. And down the line, after the UGDP study, it went into disrepute because of the performance of metformin. And after the UKPDS, then there was a renaissance. But we have been consistent in our metformin approach, not necessarily for just the metabolic aspects. I think nowadays, every journal you look into, the advantages of metformin are so much. It probably is one of the molecules. The conventional criticism is diabetes is a disease in the liver, the skeletal muscle, and the adipose tissue. Metformin acts only on the liver. In fact, even one of the great stalwarts in the field of diabetology, like Professor Ralph D. Franco, always makes a mention. It is not. But I feel endothelium is one aspect. See, everything now boils down to endothelium. And then the insulin resistance in endothelium is corrected by molecules like metformin. So, if you have a holistic approach, metabolic endpoints, predominant action on the liver, then anti-malignancy properties, endothelial function, aging, and probably it's such a pleiotropic molecule that I would like to introduce and then sustain the maximal tolerated dose, of course, with the participation of sulfonylureas, because maybe that will enable him to have some weight gain.
Yeah, I totally agree with Dr. Venkataraman. Definitely I would start him on insulin initially. Remove the element of glucotoxicity, give rest to the pancreatic beta cells so that some of the cells revive. And then maybe, if you are very confident that this is still type 2 in the young, you can start. And these are all era of combination therapy. I think we'll go for combination, as Dr. Venkataraman said, maybe a glimepiride with metformin, not the older version of sulfonylureas. And I don't know whether Dr. Venkataraman will agree about the combination of DPP-4 inhibitors in this patient.
Yeah, absolutely. I think the verified trial gives so much of a clinical message to the clinicians. A combination of DPP-4 inhibitor with metformin is able to postpone drug failure significantly. Absolutely. But in here, as I keep on repeating, your I wouldn't say a soft agenda. One of the agenda is to improve his weight. To that extent, maybe about a couple of kilos of weight gain or 1.5 kilos of weight gain with sulfonylureas will be welcome. It's a question of discretion.
Yes, sir. Yeah, please, sir.
I would start this patient on insulin straight away. I would give a trial with an oral anti-diabetic drug, either a low-dose sulfonylurea or a DPP-4 inhibitor. Let him, if he is on good control, we'll postpone the insulin. As long as he is able to be controlled on insulin, oral drugs, I wouldn't start on insulin. There is no need to start on insulin, except probably you say the weight so BMI 17. Probably BMI may improve with sulfonylurea. So a small dose sulfonylurea is ideal, and it will be more acceptable for the patient also. Straight away at this stage, if you are going to start on insulin, he is going to go into the net and see that he's got negative, why he started on insulin. Probably he'll change the doctor, that's the only thing he will do. So I would start this patient on a low dose sulfonylurea.
Sir, with those lessons, does the diagnosis by any means change, if the same guy with the same lab parameters, with the same history, everything, suppose if he comes from a remote village, some Kugramam near Vellore, and his father is a daily wage. So now does this changing of the socio-economic status changes the approach to our patient by any means, sir? From Vellore, daily wage.
I wouldn't. Maybe the type of insulin, maybe you can, of course, good amount of, you have got the various analogs and all, which most of us are comfortable with. If the socio-economic factor is going to be a deterrent, I will not deviate conceptually from the way I approach to this patient. Maybe I would like to accommodate molecules.
But does it give you a clue that whether this patient would have had malnutrition in the early week?
You're coming to type 5?
Type 5, that's what it's like.
Okay, so whatever it is, even it is there, since the C-peptide is there, as Anand rightly pointed out, yeah, you cannot say somebody is wrong if he started on OHA also. But will his hailing from a remote village and then the socio-economic status will have a bearing on the treatment by concept? I wouldn't compromise on that. But certainly take that into consideration when you want to accommodate the molecules so that it is much more patient-friendly, affordable, and then he can sustain it over a period of time, be it insulin or OHA.
What are the features if suppose if that is present, you will think about type 5 diabetes in this particular patient, sir?
I think it's a beautiful concept. If I remember right, we did it in our journal club. I think you did it, this paper. Yeah, type 5. I think that's why Rajesh is asking a lot of questions. I forgot most of the aspects. Only thing is, this was some of the pioneering work done from Vellore. I think they arranged for a huge international update on this. Right now, the clinical features, the pattern, and then even the mode of intervention, there is no consensus. It's evolving. But the message is, malnutrition in the early part of the disease can be contributory to the diabetes mellitus, which doesn't fit in with existing categories of, say, your type 1 or type 2 diabetes mellitus, or even the other types of diabetes, which have made a tentative entry into the nomenclature of the classification of diabetes mellitus. So certainly I would like to consider, but I thought it is more from the point of view of an academic point of view, whether the malnutrition at the time of birth or soon after birth in early childhood would have contributed to the beta cell dysfunction is absolutely theoretical. Maybe it gives scope for, again, aggressive approach. As I keep on telling you, if the C-peptide is reassuring, fine. But maybe in such cases, eventually they'll require insulin.
Sir, so once
the ADA is said to approve the type 5.
But IDFS...
it is only a revival. We have been, Professor Harigaran is there, an expert on malnutrition-related diabetes. He has done so much of work in MMC. So I think we believed in that, but now, I don't know.
So one last point which needs clarification is, sir, he has a low C-peptide reserve. Random is about 1.8. Still, are we going to start, in case if we are putting on insulin and he is still maintaining on this C-peptide, are we justified when we want to convert them on oral drugs, sulfonylurea and DPP-4 are justified, sir? Are we okay with that? Like, or
Yes,
what should be our approach be?
As I told you, we do come across, but I'm careful in giving the label. Instead of saying type 1, query type 1, query type 2, type 5, etc., I feel the functional diagnosis is much more. Lean, young, diabetic with, I keep on repeating, I am fond of that somehow, because that explains in total. Maybe it sounds like a dermatological diagnosis, wherein a lot of 5 or 6 words will be there in the diagnosis. It just means it's a plaque lesion or a raised lesion, or there is scaling or no scaling, etc. Maybe similar to that, not to ridicule other specialities, but sometimes the diagnosis can be much more descriptive, which will support the prescription that you have given, number one. And number two, if he is going to go to another facility for the treatment, the doctor knows what you have done and why you have done it.
So I think we had a good learning from this particular patient. I think, yeah, you're ready with the second
We'll
case.
go to the next patient,
yeah,
sir.
Please.
Similarly, all 3 patients that we are going to discuss are 19 years old. Only the BMI differs. So the first patient BMI is less than 20. Now we are seeing with a BMI of 24. Again, a male. He has mild symptoms of fatigue and tiredness, polyuria for about 3 months. He wakes up at night once or twice in a day. There are again no features of insulin resistance, though by Indian standards his BMI is slightly on the higher side, more than 23. Again, this individual doesn't have no features of insulin resistance, no abdominal pain. There are no comorbidities. Again, father is earlier patient. It was 42, he became diabetic, but this father became slightly early diabetic. He became diabetic at the age of 39. He's on oral anti-diabetic drug. No issues of autoimmunity. Vitals are all stable. And his lab parameters are 160, 245. A1C is about 8.3. Hydration adequate. Urine ketones negative. So we will now with these findings, except nothing much changed.
Everything is same. Only the BMI.
Except
BMI
the
is
BMI
24.
has changed.
Yes.
So are these data sufficient enough to initiate treatment? Now the patient is in front of you, sitting here right now in your consultation, sir. What are we going to do for this patient?
So again, to arrive at a functional diagnosis, classification, I will rule out type 1 diabetes straight away. Absolutely nothing to suggest that this can be a type 1 diabetes. This can still be a young onset type 2 diabetes. Again, if there is 3 vertical transmission in the generation, then I'll think of Modi. But of course, one more addition at this age group with this picture will be a LADA, a later onset type 1 diabetes, autoimmune diabetes. So definitely LADA also I will consider. But again, LADA is going to be very often is a retrospective diagnosis. You start them on treatment, OHA, they deteriorate, they require insulin within a very short period, then I say that it's LADA. But
that means you will suggest autoimmune antibody testing in this particular patient?
Yes, again a series of autoimmune tests. But again, I would like to emphasize, I think Dr. Venkataraman and Dr. Anand Moses will agree, the absence of immune bodies, antibodies is not a contraindication for diagnosing either type 1 or LADA. In fact, in the population very often, by the time you make a diagnosis, autoantibodies may not be positive. Thank you.
So in that case, would you want to look into the beta cell reserve of this particular patient? You want to do a C-peptide for this particular patient, or you will be happy?
Well, definitely C-peptide will give you some clue about.
So without looking into the C-peptide, we will not be starting oral drugs for this particular patient?
Yes, definitely I will go for C-peptide.
Okay. So have you done the C-peptide here?
Yeah, we have done the C-peptide.
Yeah.
So the GAD antibody is positive and the C-peptide is after food is about 3.4. Sir. So what is our inference here, sir? How do we go about it?
React to this?
So autoimmune positive with a good beta cell reserve. So what could be our working diagnosis right now, sir?
It would be a type 1, slow onset type 1 diabetes.
With a good C-peptide reserve?
Yes.
Still could be?
Still could be. But we have to do other antibodies also. If we have one more antibody positive, probably I'll be more confident in labeling as type 1. But it still could be a slow onset type of type 1 diabetes.
Like a LADA-like picture?
Yes, it is LADA-like picture.
Yes.
He will ultimately require insulin.
Okay.
Sir, couple of clarifications here, sir. When we say what is the concern
Gauri,
about?
we can ask some suggestion. Anyone from the audience? Dr. Vilman, you want to comment anything on this patient?
Interestingly, once the GAT65 has come positive and C-peptide is reserved, we now know there are various phenotypes even in type 1, like A plus, B negative, and A plus, B plus. So this is the A plus, B plus, where both antibody is positive as well as the beta cell reserve is good. So this could be one of the earlier signs, earlier onset of type 1 diabetes, most likely, I think. And this is bound to progress gradually. And this is the time these patients should be treated with insulin. Because if we treat them with oral drugs, their progression to type 1 diabetes will be much, much rapid.
Fantastic, sir. So one clarification here, sir. We have been reiterating again. Yeah. Thank you, sir. So we have to do 2 antibodies. What is the need for 2 antibodies, sir? Why should not we go with only GAT? Because that is a cheaper, widely available. So can we just go with 1 antibody, or should we?
No, idea of doing GAD is glutamic acid decarboxylase anti-GAD is for the simple reason of all the antibodies, this probably for a longer
period.
So if you have the opportunity to screen these patients for autoimmunity in the first 6 months, I think the titer is so good that most of them are positive. But if you probably do not have the opportunity to investigate, maybe down the line, even after 6 months, your chances of picking up GAT positivity is very high. That's why we are harping on GAT. That's number 1. And of course, I think LADA or slow onset type 1 diabetes is the appropriate diagnosis in this particular patient. 2 things I want to do. This is not the classical age group of LADA. That's number 1. And number 2, if this patient is on OHA, in my opinion, clinically it's perfectly justified as long as your C-peptide is good. Because we don't have to ridicule anybody who has started this patient. You can always say, initiate a conversation with the patient that he might be a candidate for insulin because there are certain things going on in the pancreas. Let's see how much, because our endeavor should be to control the blood sugar as much as possible, maybe a target of 6.5, it could be achievable, and sustain it for a period of time before we introduce insulin. I think that will be the clinical approach. If Madhu and...
So the second point that we needed a clarification is this C-peptide, sir. So the first patient we did a random C-peptide. Now we are doing with a postprandial. So what is this random postprandial or fasting C-peptide? If at all given a chance, what should because it involves cost. So should we ask for fasting post-prandial C-peptide or a random C-peptide, or how to approach this C-peptide?
I think in clinical practice, we always do a fasting C-peptide. That is usual practice. Sometimes we do a post-challenge, post-meal also we do. But fasting C-peptide is good enough in my opinion. Anand, you want to tell something?
Generally, I do both the fasting as well as stimulated C-peptide, which is high, probably shows a better, beta cell reserve.
Stimulated C-peptide will give a better idea
both,
of the...
if we have both.
Okay.
Actually,
Suppose the stimulated C-peptide is 3 or 4 times more than the fasting, then probably the beta cell reserve is good.
So probably if say C-peptide
Gauri,
fasting is...
what I thought was, yes, theoretically, conceptually, I think a stimulated C-peptide is much more meaningful from the therapeutic point of view. But the standardization, probably the values are not, if I remember right, uniform enough, whereas for the fasting you have. So on the one hand, you have a theoretical basis to opt for a stimulated C-peptide, which gives you, if you are, the measures that you are adopting, the secretagogues that are going to be effective, or certainly it is, but the fasting gives the basal insulin reserve. I think that's why we are doing it much more often. The postprandial or post-glucagon, that's what in many of the centers they do.
Or mixed meal
more
test also we can do. Mixed meal test.
Mixed
That's a stimulated. That's a stimulated.
But the standardization, I'm not too sure whether it is there.
So can we say that if mixed meal test, post-mixed meal test, if C-peptide is less than 0.6, we are ruling in type 1. If it is more than 6, we are ruling out, means we are confirming type 2. Can we say
at that point of time, so if you're going to pick up a patient with slow onset type 1 or LADA in the early part of the disease, the antibodies are positive, the C-peptide is brisk enough at that point of time. You're not too sure how long this will sustain. So I think it will not be out of context to quote, in the UKPDS also a good chunk of patients had antibody positivity. So in the so-called umbrella of type 2 diabetes mellitus, there is a surreptitious entry of a good chunk of patients who might later on turn out to be the slow onset or the LADA type of cases.
Yes. And again, with respect to C-peptide, always we simultaneously do a blood glucose monitoring also, sir. So we have to compare the blood sugar level, because what happens is that when the patient is having glucotoxicity, when the blood sugar is too very high, when the HbA1c is too very high, probably your C-peptide level will be low on that particular time. So in that case, what we have to do, we have to again repeat the C-peptide after achieving near normal glycemia. So fine.
So the point is when the sugars are higher, never do C-peptide.
Yes.
It will be misleading always.
In case if you do also, we have to repeat it after achieving near normal glycemia. That's the message.
Help at all. So don't do as well.
And again, another one tricky question, sir. We have this patient having GAD65 positive. So if it is LADA, we know that the first degree relatives of people with LADA also will be having autoimmune positivity. So would you like to screen them also with antibody testing? In case if we do it, do we have any actionable measure to prevent the progression of diabetes in those people, or what else we are going to advise those people?
I don't know. We don't do it in practice.
Yes,
Screening a relative for LADA is extremely difficult. In fact, population screening even for type 1 diabetes is not advised. Normally, most of the recommendations do not advise population screening. Maybe close relatives or accompanying person, spouse.
And even if that is positive, we don't have any actionable measure to retard the
nothing
progression.
to prevent it.
Yes.
There is always a retrospective diagnosis in that case, no, sir. So patients, we start them on insulin early, then that is how we come to know that they have LADA, then all these pictures.
In LADA, most of the time they are put on oral agents. They are diagnosed as type 2, put on oral. The control deteriorates very rapidly, very short period, within a short period they require insulin. That is LADA. That is the usual clinical picture.
So this
Some
still
of
could
the
be
ancillary parameters might give some soft signals. For example, if you do a lipid profile in this particular patient, if the triglyceride is say 96, 102, then probably you are not dealing with a case of insulin resistance or anything. Whereas in the same individual, if it is going to be 280, then that's yet another parameter for you to harp on insulin, which we have found it in practice. So the phenotypic markers of insulin resistance, triglyceride, HDL, and of course blood pressure. It's always worthwhile keeping these. They can have some additional soft inputs.
So in this particular patient, what we are suspecting is a slowly progressive autoimmune diabetes with a preserved C-peptide at that point of time. So what is that one oral drug, one class of oral drug which we will not prefer in this particular group of patients, sir? Are you, can we liberally start any oral drug for this particular patient? Any class of drug you will be little will be reserved.
You're asking whether we can give SGLT2 inhibitors. So obviously, when you're entertaining a diagnosis, but I tell you, maybe this is an academic forum, I just maybe I stand to correction. I have introduced SGLT2 inhibitors off-label in a good number of LADA patients after explaining the risks and benefits. So of course, we can always do it because the benefits of these molecules are so much, and I totally agree with you. Certainly, this is not going to be the first prescription in this particular patient. Maybe I think in this patient, a combination of DP4 and metformin will be very, very appropriate. Of course, as I told, I'm sure they'll all agree. Initiate a conversation that he'll be a candidate for insulin down the line.
With respect to sulfonylureas, would you avoid sulfonylureas in this group of, in this?
I wouldn't. If DP4 inhibitor and metformin is going to bring down his HbA1c to around between 6.5 to 7, I'll be happy. So maybe, if the response is not good, certainly you can substitute one of the doses of DPP4 with the sulfonylurea. But with a BMI of 24, I think DP4 and metformin should be adequate. And down the line, if he develops CKD, if he is a candidate, certainly I'll explain the benefits and risks. Of course, this is off-label. This is off-label because some of us, at least myself, Madhu knows that I'm biased. I'm terribly biased towards the SGLT2 inhibitors. I feel, as Dr. Braunwald said, they are wonder drugs of this century.
I will be very reluctant to start SGLT in this patient. Start him on SGLT. Yeah, definitely. Definitely, I'll be very reluctant. Yes.
Sir, in case if we are starting on SGLT, what precautions should we tell the patients? As a doctor, what should I tell the patient when he should come back? Means probably they may be developing some euglycemic.
The only problem very often we face is urogenital. Again, myself and Venki differ on this very strongly. But I strongly believe that...
apart from urogenital.
Apart from that, I think
when should say like...
some weight loss will be there. Some weight loss will be definitely there. They lose 3-4 kgs.
In a case of suspected type 1 diabetic or proven type 1 diabetic subject, the delicate balance between the insulin and glucagon is so much, the metabolic perturbation will be accentuated by that little extra glucagon that the SGLT2 inhibitors facilitate. So that can tilt the balance towards ketosis. That is the argument. So the ambulant ketosis, which we call it euglycemic ketosis. We used to call it as ambulant ketosis in MMC, which I thought was a very, very, again, a functional state of ketosis. You find out the ketones in the urine, the patient is reasonably well preserved. So whatever it is, euglycemic ketosis, that's because of that. That risk is always there. And I tell you, good number of LADA patients are there. In fact, quite often, when they do have an intercurrent illness, the ketones are trace or single positive, and knowledgeable patients, and good number of my own classmates and doctors who are type 1 diabetic subjects to LADA, they are on SGLT2 inhibitors. So just trying to say, yes, that risk is always there. That risk is there. Certainly, initial prescriptions, I wouldn't entertain, having documented a GAD positivity.
Sir, one final question on this is that slowly progressive autoimmune disease with the preserved C-peptide, but eventually the C-peptide level can fall in this patient at any point of time. So do you follow this patient with serial C-peptide level? If so, at what interval you are going to repeat the C-peptide?
Again, my take will be, supposing you start this patient on an OHA combination, maybe DP4 with metformin, and then maybe introduce or substitute DP4 with LCU. If the control is not good, then you know that what you're dealing with. So to improve upon the patient, certainly at that point of time, I expect the C-peptide to come down much more, to tell him that your pancreas is failing, you require insulin. That will be one clear-cut indication wherein to do, rather than from the academic point of view, whether he is just how progressive he is, maybe if your academically interested patient can afford, you can do it. Otherwise, from the point of view of the patient, if you want to introduce insulin, for you to have that justification, certainly a follow-up C-peptide will be required.
Sir, even if GAD65 is negative, suppose that the same picture, still she will do we hopper on C-peptide monitoring for this patient, sir?
If the GAD is negative, I think that diagnosis is straightforward. It is type 2 diabetes mellitus. Age 19, you have got a BMI of 24, then your GAD is negative, C-peptide is preserved. What else you can ask for?
Age 19 years. Sir.
19 years, okay. Young onset, yes.
In my opinion, if with maximal dose of oral agents, whatever is the age of the patient, whatever is the clinical parameters at the time of diagnosis, if there is worsening of the glycemic control, I will definitely consider at any stage in the disease process a C-peptide estimation, at least to convince the patient that he requires insulin.
So this is something which we had discussed now based on the C-peptide and beta cell, which we all can have. So this is the famous. So you want to tell something on this alpha beta classification?
Some of them are taking the pictures, let them do it, because it's a beautiful slide. It gives you about the functional status of the approach to a diabetic patient with the limited gadgets that we have with us.
So this will be the carry home point.
Okay. So I think we had good learning from the second case. With this, let us move to the last case. Again, this is a patient, again, 19-year-old male, but look into the BMI. BMI is 34 here. So he's obviously an obese individual with a BMI of 34. Now, look into the symptoms: mild fatigue, tiredness, polyuria, polydipsia, nausea is there, as well as abdominal pain is there for this particular patient. And again, there are features of insulin resistance. Acanthosis is there, abdominal adiposity is there, and you can see the waist-hip ratio is somewhere around 1. Otherwise, no comorbid condition is there in this patient. Father is also a diabetic and on OADs from the age of 42 years. Mother had GDM, so strong history of type 2 diabetes is there in the family. Otherwise, no autoimmune disease in the family. Vitals are stable, and only thing is that this patient has abdominal pain also with polyuria, polydipsia, and nausea. Can we go to the next slide? Yes. So if you look into the laboratory parameters, an obese individual, 19-year, with certain symptoms, blood sugar is 420, HbA1c is 12.8, and urine ketone was positive. Obviously, plasma ketone was also done for this patient, which was eventually positive. Hydration was adequate at that point of time, and GAD65 was done for this particular patient, which turned out to be negative. At that point of time, since the blood sugar was too very high, C-peptide was not done at that point of time for this particular patient. And since the patient was symptomatic with the urine ketones positive, plasma ketone positive, all these things, so patient had to be admitted, eventually has to be pushed into the ICU because patient had features of diabetic ketoacidosis, and that's why he was managed in ICU, and he was managed with insulin with adequate hydration, and again discharged with the basal bolus therapy. And at that point of time, when the blood sugar became normal, C-peptide was done for this patient. Here it is a random C-peptide which was done for this particular patient. Blood sugar was simultaneously done, was normal, and at that point of time you can see he had a good beta cell reserve. 5 nanogram per ml was the C-peptide. And since the patient had a recurrent hypos because he was on basal bolus, slowly the insulin was tapered, and looking at the C-peptide reserve is there, the beta cell reserve is there, insulin was slowly tapered and started on oral drugs. The oral drug is metformin with the DPP4 inhibitor. So this is the case here. So let us learn from our experts here. So you have a young individual having a BMI of 34. Let us hear from Professor Anand Moses sir. So BMI of 34, an young individual, and having classical symptoms of diabetes, presented with 420 the blood sugar level and urine ketone positive. Everything is there, and patient landed up in diabetic ketoacidosis. But what is important here is that this patient did not have any precipitating factor. No stress, no intercurrent illness, nothing like that. So no surgeries, no other comorbid conditions. So what could be the reason that this patient, even having a good beta cell reserve, obese, doesn't classically fit into a type 1 picture, looking like most probably like a type 2 picture? What could be the reason that this patient would have developed a ketoacidosis even without any precipitating factor?
From the history and
what could be the working diagnosis?
History and other point, first slide which you showed, it looked more like a type 2 diabetes.
Obviously.
With the features of insulin resistance, acanthosis, and comorbidities. But quite often at the time of diagnosis, sometimes we see very high blood sugars, even in type 2 diabetes, 300, 400 with ketones positive. Probably there is some increased insulin resistance or so when the sugars are high, very high and ketone is positive, I think what they have done is right. Initial treatment is with insulin, with subsequent changeover to oral anti-diabetic drugs. I think it's quite a common feature which we see most often, these features at the time of diagnosis.
So it doesn't look like a type 1 just because ketone is positive, just because the patient landed up in DKA. Because obviously other features are not supporting it. The antibody is negative there, as well as you can see the BMI is 34, which is very unlikely for somebody to develop type 1 diabetes at that BMI. Yes, sir, please.
I think ketosis prone type 2 diabetes mellitus.
Yes, sir.
This is the working diagnosis, functional diagnosis.
Yes.
Now, I want to emphasize.
It should be recurrent.
Yeah.
This is at the time of
Correct.
diagnosis ketosis.
We do not know. Here, the metabolic decompensation has occurred probably because of the insult from the insulin resistance and the obesity. So, the approach, an episode of metabolic decompensation does not warrant a label of type 1. I think this should be the message in this particular case. So, it's a ketosis prone or presentation with ketosis. I think, as Anand nicely pointed out, when you say ketosis prone, at least you have documented few episodes of ketosis. So, ketosis, presentation with ketosis, a type 2 diabetic patient. So, the approach will be certainly to correct the ketosis, to eliminate the glucotoxicity, bring down the blood sugar level. Then, as you nicely pointed out, I think there is an opportunity to de-escalate insulin and totally withdraw insulin. The strength is by features of insulin resistance and the brisk C-peptide that this patient has. This will be a candidate down the line to be started on, because the age is 19. Above the age of 18, they'll be candidates for GLP-1 receptor agonists. So I would suggest this patient to be initiated on GLP-1 receptor agonist and metformin, slowly tapering of course, the insulin which you have done already, and maybe the sulfonylureas. And down the line, I will also try to introduce an SGLT2 inhibitor, because I have had quite a few cases. I'm sure many in the audience would have had such cases. I've been fortunate enough to have, and all of them have been women patients in the population presenting with ketosis, obese, with telltale classical signs of insulin resistance. Initial treatment with insulin, bring down the blood sugar level, normalize. It's a relatively an easy process in these individuals, I would say. And then switch them over insulin, off insulin. They are maintaining, once they lose about 10 to 15 kilos of weight, I think the pattern is so good, so nice, you are able to continue for a longer period of time. So my approach is certainly ketosis, fluids, insulin, stabilize on insulin, and then gradually withdraw insulin, introduce OHAs, and then probably it won't be much longer before you consider a GLP-1 receptor agonist. And maybe, certainly, I would introduce an SGLT2 inhibitor also. A word of caution, not simultaneously, not concomitantly. Yes. Initiation in such an individual with both a GLP-1 and SGLT2 is fraught with the risk of ketosis, euglycemic ketosis, because on the one hand, you are going to have a patient probably already presented with ketosis. Now, when you give a GLP-1 receptor agonist, the blood sugar comes down, so the endogenous production of insulin comes down for obvious reasons. On this hand, if you're going to give an SGLT2 inhibitor, maybe the touch of glucagon at that point of time might trip. This is there in the literature, not very common, but not uncommon as well, so that it will be worthwhile in clinical practice not to initiate such patients simultaneously on these two classes of patients, rather sequentially you can initiate.
So you said that this patient is ketosis prone diabetes.
Yes, Dr. Rajesh.
Yeah. Yes, sir.
I just came halfway through when you were presenting. I wanted to just make you refer to two papers published on this subject. One is by Pirat et al. In Diabetes Care almost 15 years ago, and also by Ralph DeFranco from New York. What Pirat published was that in young people who get diabetes, and according to the European population, young is about 40, 45, they get a presentation of what's called florid diabetes. And the blood sugars come with 400, 500. And they are actually type 2 diabetes. But there is glucose toxicity, and the C-peptide is very low. And they are obese and classical type 1. But the sugar is so high that you actually think it may be type 1 diabetes, but they'll respond to oral hypoglycemic agents. Now, this is peculiar also of the South Asian population from New York, and that is what Ralph DeFranco. Some of this florid diabetes occurring in young people is pretty peculiar to the Asian population. They are actually type 2 diabetes. However, because they are obese and young, they remain asymptomatic for a pretty long time, and they can tolerate high blood glucose without much symptoms. So by the time they present, they may have even ketonuria, blood sugar will be 400. So this is a well-known entity described almost 15 years ago.
Correct.
Thank you.
I am subject to correction. The so-called ketosis-prone type 2 diabetes, what the literature says calls as Bush diabetes,
Flatbush
which is more common in the
Flatbush.
more common in the African Americans, if I remember correctly. That we don't see it in India. I don't know, I'm subject to
No, the
correction.
literature says it is common even among Asians, Indians and all.
Correct.
Sir. The recent, some of the publications have
Yeah. Because more it is a feature of African Americans.
So having said that this is a ketosis prone diabetes, how different it is from a classical type 2 diabetes, sir? This patient, will he have another episode of ketoacidosis in future? Is there a risk?
Or should we go back to this alpha beta classification?
My
and how do we
limited
need to
experience, accepting the initial presentation, there have not been, of course, the follow-up has been, I've got about 4 or 5 patients, to be very frank with you, and all of them are doing so well with the combination of the 3 molecules that I have.
So initially they present with ketosis,
Presenting
but
with
subsequently
ketosis,
they behave like
that's
type 2.
because I believe the combination of the obesity with the insulin resistance, probably the metabolic decompensation has occurred. As I told you, it's entirely different conceptually, pathophysiologically from what's happening in an autoimmune mediated type 1 diabetic going in for ketosis. I think that is the difference. So maybe if they've got a fulminant infection, like any type 2 diabetic mellitus, they're also probably the risk of ketosis is there, but that should not curtail our enthusiasm to opt for more weight loss and other means of intervention which are available today.
So how quickly after recovering from a DKA you will initiate SGLT2 inhibitor in this particular
absolutely relative, maybe a few months, and then you know the response. For example, in a type 1 diabetic subject also, for a comparison I'm telling you, if they recover from DKA initially, they do not achieve the target blood sugar levels immediately. There is always a certain amount of, excepting in few patients who can go in for the honeymoon period, etc., etc. Whereas in these type of patients, you are able to achieve the glycemic control, I would say, in a reasonable span of time. So that gives you the confidence, yes, the C-peptide is good, this is a type 2 diabetic mellitus, maybe that gives an opportunity, roughly a few months in my opinion. That's just purely arbitrary, it's up to our individual discretion in my opinion, clinician's discretion.
So one basic question, sir, in any of these patients, patient 1, 2 or 3, does any of them need a statin, sir? Statin?
Statin. Yeah,
especially
we are
the
not
patient 3.
Given the lipid profile, so if certainly
Say,
in the third case,
second case 130,
the third case certainly, I'm sure this patient should have had a, what shall we say, a very, very unfavorable lipid profile given the obesity and the uncontrolled diabetes mellitus. So you need to target the LDL to possibly around 100 or 70, if people will agree with me here. And maybe in the second case, you can do a lipid profile if it is going to be maybe LDL cholesterol more than 100 or 130 a statin, and possibly not in the first case of the age group of 17. That maybe is purely individualized, but certainly in the last case, he will be a candidate for an estimation of lipids, and I suspect this patient will have very severe hypertriglyceridemia as well, so that you need to address both the LDL as well as the triglycerides, especially in the last case, and if need be in the first 2 cases as well.
For triglyceride, I think we will wait for the blood sugar to come down. I don't think I will start him on any
unless it is more than 500.
And below 20 years, 19 years, Venki, you think we should start him on statin? I'll be a little skeptical.
No, the same patient probably if he has an LDL cholesterol of 170, certainly there will be a case for, because nowadays you come across a lot of young people going in for cardiac problem, but not in this profile of a lean diabetic individual. But here, even the LDL cholesterol is very high. Beyond that, has to be captured by the guidelines, I think we need to act.
Any quick comments or inputs
before
from the audience?
we conclude, sir, I would request all 3 of you, one key learning point from all these patients, sir.
Yeah.
One key learning point for the audience before we take few questions from the audience.
Age may be the same. You can have different patterns of diabetes. That's number 1. That's what I have learned. Number 2, it's always worthwhile to have an initial diagnosis, working diagnosis, and then possibly stay put on a functional diagnosis. And if you're lucky enough in such an age group, go for an etiological diagnosis.
Definitely, I will say that it is not necessary that you should have a definitive diagnosis at the initial visit. You always go by the clinical picture, age, family history, and all that. Depending on the glycemic parameters you treat, then you can always arrive at a diagnosis at a later stage. Maybe not in all cases. See, in 95% of the cases, diagnosis is very easy. But in a small percentage of cases, sometimes you may come across a difficult situation where you can always wait for the things to settle down and then arrive at a diagnosis.
See, all young diabetes with ketone positive are not type 1 diabetes. All young are not type 1 diabetes.
Absolutely.
You also have to think of other types of diabetes, particularly if the presentation and the clinical features are different. That's it.
So more than the phenotype, we have to look into the biology of the profile of the patient. Yes. Any quick comments or inputs from the audience before we could wind up? Yeah, please, sir. Rangarajan sir is there. Can you give me a mic? Yes, sir.
He's audible without a mic.
So in the first case you said about 17.5 is the BMI.
Yes.
And the judges said you have to increase the weight by giving insulin. My simple question is, why not PIO 7.5 to give in this patient just for increasing his weight? What is the barrier to start?
There is no evidence of insulin resistance.
Yes.
When there is no evidence of insulin resistance, there is no question of any sensitizer, especially like PIO.
The predominant
Because
pathophysiology
you
there
said
was...
MET will act only on liver, and PIO will act on the muscle as well as on the fat. If you can
Provided
give,
there is insulin resistance. In the first
Yes.
case, there is no evidence of insulin resistance at all.
but you suggested to give metformin, sir.
Yeah, that is because not only for the metabolic point of view, metformin has got so many other advantages. It is a huge, the profile of metformin is unbelievable. We are in fact learning about metformin every year, I would say. If you are updating with the literature, I think all diabetic patients should be on metformin. Of course, when the guidelines started, it was purely from the metabolic point of view. But now I think the information gathered is so overwhelming that metformin should be part of the therapeutic armamentarium in almost all the diabetics for everything. Endothelial function, preventing aging, your complications, malignancy, and so on and so forth. Even the mitochondrial biology, possibly SGLT2 inhibitors and maybe other modes of intervention. Even metformin does have a role in that. In other words, it is so plethora of benefits are there. That's why I said about metformin. Even though, if you look at the patient, a BMI of 17, certainly, if at all you entertain OHA, SUs will be first in question.
So thank
Even
you, sir.
the latest report shows it's used for cognitive function for metformin. Another one more question, sir.
Can you have the
The
discussion?
only last
quick,
question, sir. In the last question, you said that statins are not indicated for this age group because you are thinking it the lipid profile. But it has got a lot of other pleiotropic benefits. And I think so, for every diabetic patient, he or she should be on statin, irrespective of whatever it may be. What's your take on it, sir?
Absolutely, totally agree with you. I think with this we can have the discussion if my
So,
friends agree.
last
And,
question.
Role of teplizumab, in particular in the second case, early onset type 1 diabetes, slow progression. It is FDA approved for, that is slowing the progression of type 1. Teplizumab monoclonal antibody in early onset type 1 diabetes, slow progression. Any role, sir?
We have only theoretical knowledge and the research that has been conducted in particular with that particular molecule, we do not have any experience. Neither it's feasible, whether it's available, I do not know. I have not used it. I have got only.
At present, it is approved only where the 2 autoantibody positive. With 2 autoantibody positivity, Dapiluva, and that too only in few countries. I was one who has done the clinical trial in India for Dapiluva. At that time, for 15 years, the trial was started in the newly detected type 1. And there was no benefit of putting the patients on newly detected type 1 diabetes. And then later on, the same trial had gone to those persons who are at the risk of developing type 1 diabetes. They don't know when they are going to develop, but with 2 autoantibody positivity, they may have. That trial had not come to India, but I was the one who had investigated I was part of that investigative trial, and that failed miserably all over the world, that there is no benefit of delaying someone already have diabetes. It means stage 4, and that's how the staging of type 1 is being done. So unless you diagnose someone at stage 2 or 3, there will not be any benefit of teplizumab.
Thank you, sir.
Thank you, sir. I think for lack of time, we will close the session. So let us profusely thank our panelists here, our experts here. They've served as a powerhouse of wisdom and shared their practical knowledge with us. So thank you so much, sir. It's time.
Thank you, sir. Hope you all enjoyed like we all enjoyed. Thank you all.